All right, everybody. Welcome to Coffee, Compliance, and Chuckleheads, Compliance After Dark. As always, I want to say thank y'all for tuning in, logging on, and hanging out with Eric Rubenstein, Jordan Johnson, and myself. My good friend Eric Rubenstein is trying to go a little bit more formal on us tonight.
Like Pitbull.
Like Pitbull. Actually, you know, what your t-shirt reminds me of is Cal Norton.
This
Jr.
isn't a t-shirt, my friend.
Okay. What your
this is
your ambiance, your ensemble, not ambience, but
short sleeve tuxedo.
Your short sleeve tuxedo. What it reminds me of is a scene from the movie Talladega Nights, the Ballad of Ricky Bobby, with Cal Norton Jr., where he says, let's see if I can get this right. I like to picture Jesus in a tuxedo t-shirt because it says, like, I want to be formal, but I'm here to party too. Because I like to party, so I like my Jesus to party. You, my friend, are here to party.
Yep. The only thing short is he just next time for the next episode, he'll pull up with that t-shirt in his El Camino and he's in.
All right. So before this thing gets too far out of control, again, I just want to say thank you all for tuning in, logging on, and hanging out with us. We are so grateful that you all are choosing to spend your evenings with us when you could be doing so many other productive things with your life. But I think tonight we have an outstanding lineup of topics for you. Jordan's going to go ahead and let's jump in, kick this thing into high gear, because I know that there's two major settlements and there's a couple of things going on in the operational world that you really wanted to talk to. So Jordan, go ahead. Kick us off, my friend.
Yeah, no, absolutely. And glad everybody can make it and looking forward to this. Yeah, it feels like we see a lot ramping up here. Kind of what we talked about is every month it's just more and more. It's just kind of like our fun. It just insurmountable. It just keeps growing and growing and growing. It's like the pressure of fun that Chuckleheads bring. But I wanted to touch on, we talked about opioids last week, and we did see a settlement in West Virginia, and this was Teva Pharmaceuticals and Allergan PLC, which is a unit of AbbVie. They've agreed or that they have to pay, it's $161.5 million to West Virginia. And this was to resolve claims against them for their really alleged roles in fueling the state's opioid epidemic. And because we talked about that last week, and I think the week before we touched on, we at least always want to try to follow back up and give some updates. And it was interesting because it says under the deal, and I'm just looking at it here, it says under the deal, manufacturers will pay $134.5 million in cash. In addition, Teva agreed to supply the state with $27 million in Narcan. And so over a 10-year period. So it's an interesting settlement. I mean, you guys on here are used to numbers. I think that's an interesting one. I think it's not going to be the only one. I think we're going to see more. So it'll be interesting to see what the other manufacturers do ahead of this. So any thoughts, comments on that, guys?
Yeah, the pricing issue is always something that's always out there, right? Whether it's a generic or a name brand. And, you can go back years ago where you can look at one point, pricing came from two places. It came from First Data Bank and it came from, I believe it was the Red Book were the two. And interestingly enough, I know this because I had a case against First Data Bank and McKesson back in the mid 2000s when I was at the OIG. There was a key tam that was filed by someone alleging that there was collusion between McKesson and First Data Bank. And the issue and the difference had to do with what they considered manufactured suggested price and then the wholesale pricing. And if you go back and you look, the issue was that First Data Bank purported that their pricing was a better reflection of wholesale pricing because they surveyed the top 12 wholesalers around the country. Well, the issue really was that they only surveyed one wholesaler, McKesson, and McKesson knew that. So McKesson artificially inflated its average wholesale price, which was then published by First Data Bank. And so the bigger problem was that at the time, 46 states had written into their state statutes that pricing would be a percentage off of AWP per the published pricing from First Data Bank. So you had 46 or 47 states that were relying upon data being published by First Data Bank, which was absolutely not accurate. At the end of the day, it was a fairly large civil settlement. I think the federal share was $340 million. And then each one of the states individually signed on, and they did state settlements as well. But, it was a pretty large amount of money, because at the end of the day, the margins on the pricing is just huge. And the manipulation of pricing is huge.
It was interesting. At the very end, it said the settlement agreement is not an admission of any liability or wrongdoing, and the company continues to actively negotiate a national settlement, and that came from the pharmaceutical. So it was very, very interesting that that was the last word that they wanted to get in.
Well, yeah, and you tend to see that in civil settlements, right? These things that are released from the DOJ, this settlement is not an admission of guilt or an admission of wrongdoing on the part of the individual. Look, I get it, but I think we all know what it means.
Isn't it interesting, Sean, that in a civil settlement, the defendant does not have to make an admission of liability, but in a self-disclosure,
you do.
The provider has to make an admission of liability. And a civil settlement, to me, is obviously they're very similar, right? They're very similar in the sense that it's a civil complaint versus a demand letter. But at the end of the day, it's amazing to me that in a self-disclosure, you're going to get to pay less money back, right? You're not going to have a corporate integrity agreement. You're going to get a release from liability from an SDP, but yet a civil settlement could be double damages, corporate integrity agreement, provider integrity agreement, monitorship, all of these other things. And yet you've got to have an admission of liability in a self-disclosure, and it can't be for things like mistakes or errors or all of that. But you don't have to do that in a civil settlement. You can absolutely say, by signing this civil settlement agreement, we've made no admission of liability. We wish to resolve this matter and move on as a company.
That's right. Yeah. The only thing that you have to do with a self-disclosure protocol is you have to submit a corrective action plan. You have to be able to demonstrate that the issue that you are self-disclosing has been addressed. It's been
corrected, fixed, and this is how we're moving forward.
That's right. And then you give them a roadmap forward, a corrective action plan.
Right. But the thing is, though, is that when you do the corrective action plan, oftentimes it's really just for that one kind of slivered narrow issue. So if you're a provider who's submitting E&Ms with a modifier 25 and you shouldn't, your corrective action plan is an audit of E&Ms with modifier 25. Whereas in a corporate integrity agreement, it could be for a bunch of things that aren't even included in the allegations to resolve the matter.
That's right. Yeah, it's really interesting how these things, how these things differ, right? Because for me, I see no difference in a civil settlement with the DOJ versus a self-disclosure with the Office of Inspector General. I mean, it's the same thing. You've done something wrong. You've created a situation where there's a liability,
right?
And you're making restitution, and you're promising not to engage in the same or similar behavior that got you to the point of where you're at right now. So,
and the only difference really may be the level of reasonableness of the person you're dealing with, but that even will vary from district to district, right? I mean, you've got some districts where there's very, very affable AUSAs and civil and criminal AUSAs who are, and OSIG as well, so it's a weird kind of dynamic.
I agree. I have experienced over just the last few years, the variation in outcomes depending on who it is and what region I'm working in on behalf of a client. I've made some significant relationships, significant friends, as at OIG and DOJ. So, I always try to reach out to these people that I have a working relationship with, because I know that, you know, I know their thought process. I kind of know from experience the way that they're going to go. They know, that I'm going to make a bona fide disclosure, that I'm not going to try to, dupe them on something. But then you get with somebody who you've never worked with before. They don't know you from Adam. You don't know them. And, it's an uphill battle. And, it's kind of interesting, like, the case that you and I are working on right now on behalf of a group. you know, we believe that there are some significant flaws in the arguments that are being made by the government, but yet when you engage in a conference call with the individual at the government, they kind of poo-pooed it and, went their own direction, although they did seem to indicate, yeah, I get it, but, and they were putting on that litigator hat. So, yeah, I agree with you 100%. But JJ, I know you got something else, another big settlement. What's up?
Yeah, another one. This one's interesting, out of the District of Maryland. We talk about the timelines all the time and audits and how something can happen, when they can happen. I think this is important. This one hits close to home to me. So it's radiation oncology, a $296,000 settlement. This is a whistleblower case. And the interesting thing was the timeline. So January 16th, 2014 through July 5th, 2018 of when these services were provided. And it was, we know these services are provided under direct supervision. And it was funny, they literally went back to the definition that we all used. And it said, during this time period, Medicare covered radiation therapy and diagnostic services furnished in an outpatient setting when rendered under the direct supervision of a physician. It says direct supervision means that the physician must be immediately available to furnish assistance and direction throughout the performance of the procedure. It does not mean that the physician must be present in the actual room where everything's being done. This has been in oncology, and I'm sure other service lines too. This has always been a point of contention. And I go back to what Sean, me, all of us have said. It's just because you can doesn't mean you should. They may not find it tomorrow, but guys, again, 2014, they went back. This whistleblower was actually the medical physicist of the department. So he clearly knew what the rules were. And we have all, these rules are black and white. This isn't a gray area. And it just seems like, especially irregardless of the PHE, because this was pre-PHE, but it's just like people want to blur those lines or really bend the rules. But when it gets down to these reviews, it's pretty cut and dry, but it also brings back, how do you prove where you are when you are, and that goes into the login of the EMR, the EHR. But it was a very, very interesting case. It seems pretty much case closed. Unfortunately, we've had about 60 of these in oncology over the years, and it's all for the same thing. So just another case, another feather in the hat for just play by the rules.
Well, and Eric, I think you would agree with this, right? Oncology, radiation therapy, these are not only services of high volume, but these are high dollar targets, right? So the settlement agreements, or, the liabilities that these organizations face are significantly higher than your garden variety, primary care physician.
Yeah, I think that's right. Yeah, I think that's right. It always amazes me that when you see some of these settlements and you see that they're coming in for specialties that are really the life and death situations, radiation oncology, you're dealing with the sickest population of people in the worst possible places they could be. And, man, how do you not just get frustrated at something like that? Today, I put up on LinkedIn today, there's a press release that just came out involving a lab that it didn't say it was BRCA1, but it talked about breast cancer tests. And, they were manipulating the 14-day rule under the DRG and, similar to, as I equated it, the global billing period post-surgery. Like, you're holding a test to increase your reimbursement, But at the same time, you're absolutely screwing a human being who is waiting on the edge of their seat to find out if they're going to die or they're going to have cancer. Cancer has touched everybody. There isn't a single, it's touched my family directly. It's touched some of my best friends. It is, it's killed people we know. It's the one thing that you don't ever screw with. And when you hear stories about Dr. Fareed Fada up in Detroit, and then there's the other one that was recently doing it, which was a civil case, which I don't quite get. And then you see these, it's just like, man, the difference, as I say, the difference between a rich person and a wealthy person. Shaquille O'Neal is rich. The guy that signed his paycheck was wealthy. And at what point is enough, right? Like enough is enough.
No, and I think that's anytime you have these charged service lines. But the other thing is, with so many changes in technology, and I can tell you this leads to a lot of what we see, but these young physicians, I do a lot of young resident training and things like that. And for them, the technology, well, we can do it. So if we can do it, it must be acceptable. If we could remotely supervise, if we could remotely do something, but those aren't the rules. They haven't been updated. So oftentimes you have to go back over this historical and show them these cases. And then all of a sudden, when these things pop up, here we are 2022 and another one pops up. It's just a friendly reminder that this is alive and well.
Yeah. I'll tell you the other thing that really bothers me. And look, I know and I'm kind of going a little sideways on this, but I think it will tie in at the very end. So we just went through open enrollment for Medicare, right? It just closed. A lot of folks who have been negatively impacted, financially impacted through the last 12 months have had to make some serious decisions about, do I continue to stay on traditional Medicare and pay a higher rate, or do I shift to a Medicare Advantage plan, which is cheaper, and I have a little extra money in my pocket to be able to maybe pay for this, that, or the other? Maybe I could take my little bit. Folks, let me tell you something. Do not ever come off of traditional Medicare Part B unless you are absolutely at your very last option. Don't come off of it, because especially in oncology, you're going to find all of these major centers that are non-participating. They are out of network with Medicare Advantage and with these HMOs, because the rate of reimbursement on some of these is at the Medicaid rate or below. And to Eric's point, tying this back into the cancer, this is something you don't want to chance.
So Sean, how is it that if they are a Medicare Advantage participating provider, how is it that they are at the Medicaid rates, that it's not at the Medicare rate?
They have separate fee schedules. You would think they would be reimbursed at the same fee schedule, but they're not. Remember, they're taking in a lower premium than what's being paid to traditional Medicare Part B. They are an administrator of Medicare Part C,
right,
which is a lower level Advantage plan, and it's calculated on a different fee schedule. I've struggled with this for years.
So then that leads to your out of pockets are going to be higher. So you're responsible. Well, you're obviously responsible for whatever the agreed amount is as part of your Medicare Part C, but it certainly could be more than your 20%.
Potentially it could, right. But you see these commercials with I'm Joe Namath,
Walker,
JJ Walker, Joe Namath,
washed up old guys. And the best is when you're seeing the commercial, what do you see in the background? It's a picture of Jimmy Walker from the 70s, from Good Times, when he had, what's happening, not Good Time, what's happening, when he had the, with the hat, because the only way that anybody on this planet's going to know who he is by looking at that picture.
That's right.
Like Jimmy, JJ,
but what's happening? All this stuff, about dental coverage and free transportation to your doctors and meal services and all. I'm sorry.
Well, you bring up a good point
Yeah.
there. We've been dealing with a lot of people, and like you said, because of the pandemic, we've seen so many people now, and I don't know if y'all seen this, but drop their vision and dental, and
Yes.
most people are going pure cash only, and a
Yes.
lot of your vision offices, especially, no longer accept certain insurances
Yes.
much more than before because
Yeah.
they can actually financially do much better just negotiating cash rates with their people. That's a big thing for dental and vision now.
Yep. Jeffrey Smith, you were right. It was
yeah,
good times.
Yeah, it was.
Good
I was
times.
right. I had it right. What's happening was the guy who danced, the big dude who danced. The hi.
Hey. All right. Before we go sideways, let's get so Eric. So we're talking about we're talking about the pandemic, and I think this is a great opportunity to talk about what's going on with post-pandemic audits and what you're seeing, what I've been dealing with, what Jordan's seeing, and really where the significant liabilities are and the misapplication of billing for services during the pandemic for COVID-related services. So, Eric, take it away.
So the thing that's interesting is, so let's talk about a pre-pandemic, post-pandemic. So OIG came out in 2021, February of 2021, OIG came out with a study that said for the period of time of 2014 to 2019, there was a 20% increase in the level of severity for inpatient stays. $10 billion was spent on inpatient stays. It accounted for over 109 million services. Hold on, I'm going off of memory. So it's a huge number, $109 billion. I'm sorry, 8.7 million inpatient stays. And so, the first thing that comes to mind is when you're bringing people in at the highest severity level, the first thing is from a CDI perspective. So those people that are doing clinical documentation improvement or clinical validation, if you're an RN or on the clinical side, is how are these being missed if there's such a huge error rate in this? And I could tell you that recently, where I am, we did a review on behalf of a payer and found that there was a 75% error rate on the submission of claims under the DRG. I will tell you that we also have a bunch of nurses that are currently working on the payer side doing clinical DRG validation who came from the provider side. And I had a conversation with one of my clinical nurses that does this recently, and I said, now that you've been on the payer side, I need to know your opinion. Do you feel like the payer really is the big gorilla in the room? And she actually said, no, I don't feel that. What she actually feels like is going back and looking. She said, we were just missing the mark. We weren't really looking at the policies as well as we should have. We weren't really following the rules as well as we should have. We were doing a lot of putting this and this together, but not really putting this and this together on the same column and coming up with all of these. And she said, really, when I go back to my world of working on the provider side, she said, I'm bringing so many more tools to my tool belt to ensure that we don't get audited because I really did see such poor documentation. And so it really is an amazing thing. As you guys all know, the OIG has had for eons, the issue of inpatient overpayments and DRG upcoding has been prevalent. I mean, when we did our study, we looked at sepsis and had this 75% error rate. Now, one of the things that we looked at was length of stay. And it was really, I hate to use it, but it was like shooting fish in a barrel. We looked at minimum length of stay, and we picked a whole bunch of records that were below that minimum length of stay. And we were 100% accurate that all of the people that didn't meet that length of stay did not have sepsis. And so the question then becomes, are the hospitals are the people that are working in the hospitals doing this not up to speed on what the payer's policies are? Are the people that are doing this just poorly trained? Are the facilities just poor at documenting? Is it kind of this combination of everything, which I really think it is, because there's so many good people out there that understand this. And so the question is it that there are so few people that are really good at doing this? Or, what is it? But to see that there's been this huge uptick, And we're going to continue to see that, right? Because now with COVID, people were coming in who didn't have COVID. You know, you hear all these stories about the person that goes to the hospital with a gunshot wound. They die from a gunshot wound, but they die with COVID. And, you know, I think, and we've talked about this a million times, dying from COVID versus with COVID is not the same thing.
That's right.
And so getting that extra bump in money, this is where all these audits and clawbacks are going to be coming from. This is not going away. And I don't really like to stand on the soapbox and talk about this is the year of the audit. I think that that's really a misnomer. I think that we're in a different world where audits at the rate that they're going are going to continue. And there's one huge reason for that, because the resources that have been put into doing audits and recoveries, whether it be from a payment integrity or an SIU perspective, that money is going to continually be there. And there's going to be a continued issue with putting more resources. When I got hired as an OIG agent, I was hired during something called Operation Restore Trust, which was in 95 through the early 2000s. Money was pulled out of the Medicare Trust Fund to fund the OIG for enforcement and operations. I think what you're seeing now is a similar version of that. Payers are now pumping money into their payment integrity and their SIU teams because they're seeing that there are recoveries that can be made because providers took advantage of some of the things that weren't happening, such as audits and investigations.
I like that, Eric. I think that's I think the biggest thing that's not, I'm looking at what y'all are writing over there, like going back and forth.
No, I haven't written anything. I was wondering what you were looking at, but yeah, look, here's the thing. I think the biggest problem that providers faced was that there was a lack of consistency among the payers. And not only among the payers, but within payers from plan to plan on what was covered, how it was covered, and the expectations on some of this stuff. And as a result, it has created a tremendous amount of confusion during the pandemic. It created a tremendous amount of low-hanging fruit for the auditors to then go back and begin these significant audits. We've talked about this in the past. I have a client that, one of the payers wants $1.2 million from them because they said that the guidelines released by the AMA and Centers for Medicare and Medicaid Services said that you could never bill anything higher than a 99211, irrespective of how complex the case was that you were dealing with for COVID. Nowhere was that ever published like that. There was something about 99211, but it was a very limited component. But I see you're saying it's a different time period. And I don't disagree with you, Eric, but I honestly believe that 2022 is the year of the audit on steroids because there was a lull in the audit activity that was permitted by the federal government and by the commercial payers with the SIUs, the SMRCs, the certs, the RACs, the investigations that were done by the UPICs, the audits and investigations that were done by the Office of Inspector General. So I feel like they're playing catch up. Now, I think as we move beyond 2022, I think it becomes a new era. I think it becomes the new norm that we have to recognize the continuous threat. And it is a threat. It's a continuous threat of audit. But what providers need to be aware of more are, what do your numbers show? I mean, we right now are dealing with, and Jordan, I want your take on this, right? Because you're an analytics guy. But Eric, think about this. When the OIG says to you, I don't care about medical necessity, because we would believe that everything a provider bills to Medicare is going to be medically necessary. This is a strict liability situation because we performed an analytical review of your data and we determined that you were outside of the coverage guidance, even though it's a subregulatory document where it's guidelines, we are assessing damages.
I think that's what people are missing first, right? I mean, I think, and Eric, you talk about this a lot. Sean, we deal with it all the time. I get what they want to do, but it pops up like a sore thumb on a standard deviation curve, whether you're at the head or the tail. And I mean, it just gives them the roadmap of who they're going to contact first, who they're going to go after first. Now, you shouldn't do anything fraudulently to be more towards the middle. It doesn't make sense if somebody is 10x what somebody regionally within 10 miles is doing. It doesn't make any sense.
Right.
So, real quick, Melissa, this is such a great comment, right?
It is.
It is such a great comment. And Eric, I know, as former law enforcement, right? You see something like this and you go, yeah. I mean, I love when people say, oh, don't bother the physician. Well, guess what?
Yeah.
Deliberate ignorance or reckless disregard is not a justifiable defense. Stupidity or ignorance. There is a tremendous disconnect. Melissa, you are spot on.
There is.
Right?
The example of that disconnect is one of the first projects I worked on after retiring. A law firm that I had a connection to brought me in, and it was an ophthalmology practice. And it resonates, and I use this story a lot. It resonates. They were an ophthalmology practice in the New York City area. They had 6 locations in 4 of the 5 boroughs. They owned the buildings or the space in most of them. This was an operation that was open 6 days a week, 12 hours a day. This is not a mom and pop operation, right? Not mom and pop. 6 locations, 6 days a week, 12 hours a day. This is a business. This is the business of medicine. I'm sitting with the provider who was under an investigation from the UPIC with the lawyer. And the provider is saying to me, well, we're just a mom and pop business. We don't understand this. And I said, well, a mom and pop business is the doctor on the corner who's accepting a chicken in return for, a test. Like, you're beyond the mom and pop business. And the issue at hand had to do, obviously, with their coding. And I held up the super bill and I said, okay, who circled this super bill? And the doctor said, we do, the physicians. I said, okay, you're coding. No, I'm not coding. Well, then who's coding? Well, I have my girls in the back that do my coding, to which I said, you mean the physical typing of your information into a sheet that gets submitted? Yes. Okay, those are data entry people. Who is doing your coding, meaning who is determining that this is this? Well, we are. I said, okay, you're coding. And that really gets right back to that disconnect. And I say this all the time. Providers are very good, well, we like to say they're good, at documenting to their treatment, but are very poor at documenting to their code. And, I worked on a project recently where provider was under audit for they got audited for dates of service for ophthalmology for YAG laser, peripheral iridotomy and YAG laser, right? Ophthalmology for glaucoma. And the services were all being denied because on the date of service that the patient came in for the YAG laser, the only note was relative to the YAG laser. And so I said, oh, you're getting these denied because you've got nothing to demonstrate the medical necessity to document the need for the service. I said, however, here's the issue. The issue is that you've treated this patient for their glaucoma for a year. You know this patient inside and out because they're coming to see you every 6 weeks. By the time you've gotten to the medical intervention of a peripheral iridotomy or a YAG laser, you've already made this decision because you've been following this patient. The problem is the 4 corners of your piece of paper don't tell that story. So on an appeal, we're going to win this because you've got a patient record that tells that story. But going forward, your lesson is that you're going to have to recapitulate your previous visit going forward to explain this. Because the problem is that when there's an audit being done, not an investigation, investigational audits, very different than payment integrity. When the UPIC is looking at records, they're looking at 360 degrees. When payment integrity is looking at records, they're looking at the 4 corners of the paper. There's a little bit of a difference between those. And so the important piece of this is providers who are documenting to their treatment aren't documenting to the code, which is always going to have that requirement of a medical necessity component outside of just what the four corners say.
Yeah, I agree. It's spot on. And that's the problem, is the lack of documentation. Again, I go back to the fact that one of the worst days was the implementation of the electronic medical record, because it became a completely templated shortcut system that took the actual clinical component of the doctor thinking through everything and transcribing that to a sheet of paper. Not saying that their clinical judgment changed. What I'm saying is what went from here to here changed, because now it was a point and click.
Well, that's what I was going to say. I mean, the biggest thing we often see is, like you said, the check boxes. I don't have a problem with the check box, but that blank spot down at the end that's meant for free text to articulate your thoughts, inevitably they don't fill that out. It's the same check box for everything.
Yep, that's right. All right, so we're talking about evaluation and management services, right? We're talking about these post-pandemic liabilities. So our good friends, and for those of you that have been tuning in this week, I've started what's called the Daily Dose, and they're 5 to 10 minute segments that basically take what's going on in the world of healthcare today, and we disseminate the information and we bring it down to a 5 to 10 minute kind of, here's what it is. So coming out tomorrow on that Daily Dose will be Cigna and the Modifier 25. But for those of you who don't follow me on the Compliance Guy, and I can't say that I blame you, I'll go ahead and talk about this right now.
It is kind of boring.
Yes,
it is kind of boring.
Yeah, y'all just get ready to, after Sean explains this, to get your Amazon carts pulled up and to order a nice piece of machinery he's fixing to talk about.
All right. So our good friends at Cigna decided that they wanted to do a reimbursement policy update. And this reimbursement policy update goes into effect August 13 of 2022. Folks, stay with me, because a lot of things that are not good are about to happen. Okay? And what do I mean by a lot of bad things? Well, your revenue cycle is going to go probably psychotic. It's going to go sideways. Your requirements for resubmission of claims to get paid is probably going to increase. The number of denials that you get where appeals are going to have to be filed are going to go up. Folks, they're doing this because it's low-hanging fruit and because people have overutilized the Modifier 25. I have been in this industry since 1989. The Modifier 25 has been a significant headache since 1995 when I started teaching coding courses. So here's what our friends at Cigna, in their infinite wisdom, decided to do. And if anybody from Cigna is listening, yes, I did say in your infinite wisdom. All right. So, yes, if you want a link for Cigna, I will put something out there. I actually have the official letter that Cigna sent out to providers. Let me redact it, and I will post it. I will post it to LinkedIn following the show. Okay, so here's what it is. This is a reimbursement policy update for evaluation and management codes billed with Modifier 25 and a minor procedure on the same date. So what our good friends at Cigna has said is that they routinely review coverage, reimbursement, and administrative policies for potential updates. And in that review, we take into consideration based medicine, professional society recommendations, Centers for Medicare and Medicaid Services, CMS guidance, industry standards, and their own internal existing policies. Now, based on the review that they conducted internally, they have made a determination that evaluation and management service codes 99212, 213, 214, and 215 if those services are billed with a modifier 25 when a minor procedure is billed, you will have to submit your documentation for every single patient encounter. Folks, I did not stutter. I did not make this up. Every single 99212, 213, 214, and 215, whereby you attach a modifier 25 to the E&M because you have billed a minor procedure on the same day, you will have to fax to a dedicated line your documentation to substantiate that a significantly separately identifiable E&M service transpired on the same day as a minor procedure. And if the E&M line on your claim form does not have documentation submitted with it that supports a significant and separately identifiable evaluation and management service was performed, they will deny your service. Now, they are in the process of updating their modifier 25 policy. So literally, you can go to Cigna, CIGNAFORHCP.com. And when you go there, you click on resources, you go to coverage policies, and you go to policy update. And you will see where it's not ready yet, but effective August 13th. So remember, this update is effective for claims that are going to be processed on or after August 13th of 2022. So they're giving you a few months to kind of get it figured out.
Yeah, it says that in red at the top. Sean, you're right. It says Cigna will require the submission of documentation to support the use of modifier 25 when billed with E&M, and then 99212 to 215 and a minor procedure, and that's the red highlight at the top.
Folks, you should be going to your specialty societies.
Yep.
You should be getting your doctors going to their specialty societies, getting the advocacy group at your society involved. If you are in rheumatology, the American College of Rheumatology, the National Organization of Rheumatology Managers, the American Alliance of Orthopedic Executives, the American Academy of Orthopedic Surgeons, the Otolaryngology Association, they all have excellent advocacy groups. You need to bring this to their attention because, folks, the undue burden that this is going to place onto practices is going to be beyond anything that I think people are actually prepared for. And I think where this kind of ties into things.
Well, how far back are they, Sean? How far back are they telling you have to go?
No, it starts on August 13th. It's not retroactive. It's if you submit a claim on August 13th or after that, every time you bill a level 2, level 3, level 4, level 5 established patient office visit with a minor procedure on the same day and a modifier 25 attached to the E&M code, excuse me, you have to submit the documentation to support that line item for the separately identifiable E&M service.
Except for the fact that you might have something that's got a historical, that's what I'm saying. Like there might be historical context that separately identifiable E&M might be relating to.
Yeah.
Right. So you may only be telling half a story.
Yeah. So there's the reimbursement policy that
that's
Jordan
a lot of paper. That's a lot of paper for Cigna, isn't it?
Yeah. And that's why I said the reasonableness of this thing, there is none. And this is going to lead to mass confusion. It's going to lead to a lot of denials. It's going to lead to the untimely processing of claims, which takes me to the topic that I wanted to tie directly into this, which is the prompt pay laws. And this is really important because, again, I'm talking about section 447.45, the federal statutes. And what we're talking about are now there's two different things. You have the timely payment of claims, excuse me, and then you have the prompt pay laws. So let me quickly, if I can, I want to go through this. Let me see if I can pull this up for everybody real quick. Give me 1 second here. All right, here we go. So what I want to talk about is, and the reason why this is a tie-in is because we have to define the term clean claim, right? And a clean claim means it is one that can be processed without obtaining additional information from the provider of the service or from a third party. It includes a claim with errors originating in a state's claims system. It does not include a claim from a provider who is under investigation for fraud or abuse, or a claim under review for medical necessity. Now, keep this in mind. There are some exceptions to the rule. There are some waivers that have been put in place. There's prepayment and postpayment reviews. But what I want to point out, and I'll make this very quick because I don't want to dominate, too much more of the total time. But here's what it is, okay? If your claim requires additional documentation, okay, they are not in violation of the timely payment for claims under 447.45. Now, what they have to do is they have to make a request for the supporting documentation within a timely manner, which is within that 30, 45, or 60-day time period. Now, once that documentation has been provided, they still have to process the claim within the timely payment of claims statute under 447.45. Now, this is for your federal payer programs. This is for Medicare and Medicaid. What the commercial payers are bound to is not section 447.45. Folks, please hear me on this. What they are bound to are the state prompt pay laws. Now, out of the 50 states, only South Carolina does not have prompt pay laws that the commercial payers are required to comply with. In the prompt pay laws within the states, you have the ability to go to, and let me make sure I give it correct, because there's a group called the National Insurance Carriers Association. National Association of Insurance Commissioners, the NAIC. And it's NAIC.org. So if you have a payer that is out of compliance, go to NAIC.org. And if you scroll down to the bottom, it will say state information. If you scroll down and you find your state, it will link you to your state insurance commissioner. Once you're on their site, it will tell you how to lodge a complaint against an insurance company, a commercial payer, who is in violation of your state prompt pay law. The only thing to keep in mind is if you are dealing with a self-insured plan, they are not regulated by the state. They are regulated by the federal government. So please keep that in mind. But I can see Cigna being out of compliance because they're going to say, oh, you didn't meet the definition of a clean claim. Well, you may have, because it's not that your claim had an error. It's that Cigna created an extra step, an additional layer to require you to submit documentation if you bill an E&M service with a Modifier 25 attached. So you are not submitting a non-clean claim.
That's an important piece, because if we loop it back into the Medicare world and we talk about the NCCI edits and the MUE, so NCCI National Correct Coding Initiative and MUE Medically Unlikely edits, that the circumvention of a traditional edit is the use of Modifier 25, or in some cases 59, but Modifier 25 becomes that circumvention. And so the thing that's important to remember is that the definition of a clean claim is in part, as you said, but also a claim that is free of errors or omissions. And so and I think this is where people get hung up, the mere fact that a claim gets processed through and gets paid doesn't inherently make it a clean claim. It makes it a clean claim for the purposes of processing. But if you have something that is an error, so you've used modifier 25 inaccurately, for example, you render an E&M and you put modifier 25 on, but you do nothing else. It is just an E&M, but you blanketly put on modifier 25. That is not going to have an effect on payment. It's going to pay because the modifier 25 is just going to drop off.
That's right.
But it's not a clean claim because you have an error on that claim. And so a payer may turn around and say, we're not paying this claim because you used modifier 25 inappropriately. It is not a clean claim because you have an error. It doesn't mean that it's fraudulent, waste, or abuse. It is an error. And they'll say, we can deny payment because you put on a modifier that although it doesn't have an effect on payment. So people need to always understand that there are technical violations that do not have an effect on payment. And this is an example of that.
Spot on.
You're going to pass, the NCCI edit is going to pass. Modifier 25 is going to pass you.
Yep.
Modifier 25 with no other procedure is going to pass you because the modifier would have been useless. It doesn't affect payment, meaning that the dollar amount isn't going to change, right? It's sometimes you see in the ophthalmology world or in other procedures where you see bilateral procedures where you get paid the full rate for the first eye and you get 50% of the second when it's bilateral. I think the modifier was 50 for that one if you use bilateral procedures. So, there are modifiers that do have an effect on payment and there are modifiers that do not have an effect on payment. If you're doing something like an E&M with modifier 25 with no other procedure, the dollar amount doesn't change, your payment will come in. And so it's important to understand that a clean claim is a lot of things. It's not just the fact that it was free of an omission or that it passed an NCCI. And I think, we all have this conversation with our clients and in the fraud, waste, abuse world, that the mere fact that a claim was paid doesn't make it okay.
That's right.
I think, but that's unfortunately, that's what most people think is if it got paid, everything's okay. And then they get that letter in the mail.
That's right.
Well, and so the heart of this goes back, and I guess this is how we close out today, Sean, is the heart of this goes back to the poor advice that providers take from their billing companies. Now, this isn't to say that all billing companies are bad, and I'm not here to, put an attack on them, but as a provider, if you rely upon the billing and coding advice of your billing company, at the end of the day, you cannot point the finger at the billing company because at the end of the day, the responsibility of the submission of that claim is always going to be on you. And so it is your responsibility to ensure that when a claim is submitted on your behalf, there's that caveat. We talk about it all the time. Knew or should have known. So if you didn't know that modifier 25 wasn't proper, the argument is going to be you should have known. And it's a very, very low bar, unfortunately, to have to meet. Now, that doesn't put you in the criminal world. The I'm an idiot defense is always available, right? Because you can say, hey, these are very complicated. In criminal healthcare fraud cases, the insurer is put on trial just as much as the defendant in these cases. But, the use of modifiers, the use of what you're going to do, they're going to have that effect. When a billing company tells you, put on modifier 25 on your E&Ms, you better understand what the ramifications are, because I think the collateral piece, and Jordan, please comment on this, is even though using modifier 25 on an E&M by itself may not have an effect on payment, it is certainly going to have an effect on your analytics in your utilization and make you an outlier. So you've created an environment in which no one was looking at you, but now someone could be.
Well, and literally on that report that we run, and we can run this for anybody, but they have the access to the same report, is the CPT code and the modifier used. And if your modifier columns are eat up with 59s and 25s, that's where I'm going first, because odds are, whether you knew or didn't know, there's an issue. It's an easy red flag. But I think, again, a lot of people, especially on the 25, if we looked at it, have a billing company. And not to pick on any billing company, but I think there really is sole reliance on that billing company.
Great points. All right. So we are finishing early tonight, and that is a rarity for this crew.
It must have been that T-shirt.
Had to be.
It's not a T-shirt, my friend.
No, it's a full-blown tux, baby.
The fact that it's got short sleeves. I mean, remember the time they used to say that there was the short sleeve dress shirt, and then someone would go, "What is that?" Like a button-down shirt. So you'd see these guys show up to work in a shirt and a tie.
I do have to put this up here because this is your boss.
That is
She
true.
did not approve of this.
That is true. But the last time I checked, this was coffee, compliance, and Chuckleheads after dark.
Uh-oh. Well,
Which means I'm not on the. You know what I did? I punched
yeah, and I have a feeling something else is going to get punched. On that note, I want to say, Eric, Jordan, you guys are awesome. Thanks so much, man. I love hanging out with you guys each and every single week. To all of you who joined us, and to everybody who was engaging with us online, thank you all so much. We greatly appreciate you each and every single week taking time out of your busy schedule to hang out with us. Again, listen, I am in the process of redacting this Cigna letter. I'm going to go ahead and get it posted immediately following the show. It will be up tonight. Again, we'll be back next week, same day, same time, I believe, with a whole
Same
new
channel.
lineup of topics just for you. Eric, Jordan, any parting words?
Be good to yourselves, but more importantly, be good
to each other.
Be good to each other. Sometimes I want to say be good to your neighbor. I don't know.
All right, Mr. Rogers. Y'all have a great week. Take care. We'll see you next week.